Empowering Young Women as Community Health Leaders. My name is Jessica Condolo-Hibish. I'm the Programs Manager for the Lehigh University United Nations Partnership. Lehigh University is a private research university located in Bethlehem, Pennsylvania, so it's about 2 hours from here depending on traffic. In 2004, Lehigh became the 6th university in the world to become a UN-accredited NGO. And in 2008, we created the first Youth Representative Program. The Youth Representative Program aims to match high-achieving graduate and undergraduate students with UN-accredited NGOs that typically do not have adequate representation at the United Nations. All of our panelists here today are United Nations youth representatives at Lehigh University. Each panelist will speak for about 10 minutes. Following the individual presentations, we will open the floor to a Q&A session. Please hold your questions until this time. To engage with us on Twitter during our event, please use the hashtag Lehigh CSW and hashtag IndigenousNCDs. Thank you. I would like to first introduce Nadine Clopton. Nadine Clopton is a senior at Lehigh. She is a double major in public health and political science with a dual minor concentration in sustainable development and environmental studies. She is the first Lehigh youth representative to serve at the UN in Geneva, Switzerland. She currently serves as youth chair on the NGO DPI Executive Committee. She has been on board as a youth representative with CLAN since July 2016. Caring and Living as Neighbours, also known as CLAN, is an NGO based in Sydney, Australia. They work with a handful of countries to provide children with access to affordable care, and in their own words, CLAN is dedicated to the dream that all children living with chronic health conditions in resource-poor countries of the world will enjoy a quality of life on par with that of their neighbors' children in wealthier countries.
Good afternoon to you all, and welcome to our side event. I just would like to express my deep gratitude to you all for the work that you've done and for being here with us today. It's really meaningful that you're willing to engage in dialogue with young women and do work surrounding the empowerment and capacity building of young women. CLAN's efforts are based on a rights-based community development model that provides a strategic framework for action to help children who are living with chronic health conditions in resource-poor settings. Our 5 pillars focus action on affordable access to medication and medical equipment, education, research and advocacy, optimization of medical management, encouragement of family support networks, and reducing financial burdens on families that would otherwise result in poverty, helping people to become financially independent so that they can provide the necessary health care for their children in the long term. Earlier in this session of the 63rd Commission on the Status of Women, Secretary Guterres said that when we exclude women, everyone pays the price. When we include women, the whole world wins. While this is completely evident to all of us in the room, many people may wonder why starting with women is a proven intervention that leads to better support. So, why women? Let's start with non-communicable disease burdens. I'll be abbreviating that as NCD going forward. Worldwide, across varying socioeconomic levels, women bear the burden of caring for children, caring for their elder family members, spouses, etc., living with chronic and acute health conditions. Especially in the case of low and middle income countries, if one member of a household is to put their lives on hold to care for a loved one who is sick, it is more often than not a woman. This means that women's economic, educational, and social opportunities are being cut short by no fault of their own. Caretaking is critically important, but many women and caretakers are ill-equipped to handle the roller coaster that may accompany management of an illness. CLAN seeks to identify communities in which children living with NCDs are in need of support and local capacity building. Our work is dedicating to creating these illness-specific communities of care using a rights-based approach and providing them with the necessary information and resources to best position themselves as leaders in their own right. Community building is an imperative component of approaching women's health because when women communicate with women who are experiencing the same NCD or who are also caring for a loved one with that illness, it can be a transformative experience where illness-specific stigmas are reduced, communities are cultivated, health literacy is enhanced, knowledge is transferred, and lives are saved. When people can share knowledge with one another and feel as if they have ownership of health knowledge, it can be a powerful tool for communities to heal together. Clinical settings can often seem a little intimidating, especially in some rural settings where they may not have access to clinics all the time and may not understand particularly why someone's coming in and asking them about their health. In our focus countries, CLAN works in partnership with local medical institutions and National Institutes of Health to bring communities of young people and families together who are living with conditions such as diabetes, rheumatic heart disease, congenital adrenal hyperplasia, nephrotic syndrome, just to name a few. Especially in the case of chronic illnesses and areas in which access to care is low, community-based care is a critical step in improving health outcomes. Parents of a child living with diabetes in a small village in Pakistan, for example, may not know much about their child's NCD or how to manage their care. A community care group provides parents with adequate resources to learn and grow as health advocates with their child. Identifying vulnerable communities who may have limited access to care is key to building an equitable future. A particular community that CLAN has passionately mobilized support for in the past few years is the global community of Indigenous people. Indigenous communities have limited access to health information and services. They are underrepresented by national and international governing bodies, and as a result, these communities experience tremendous gaps in access to education and healthcare, among many other resources. Additionally, they endure significantly worse health outcomes than their non-Indigenous neighbors, at no fault of their own. In crafting interventions with that community, it's critical to seek out tribal leaders and present information in a way that's culturally sensitive and is understandable by the population the information is being disseminated to. So no two communities have the same needs, and so it's imperative to assess community needs with and alongside communities rather than for them. You have to meet people where they're at and identify the best community stream and platform for their specific conditions and communities. Taking things into consideration such as language barriers, if we create a flyer on how to contend with diabetes and it's in English and no one in the community we're intervening in speaks English, it's not going to be a proven intervention. So this year being the year of Indigenous languages, we often ask, how are we reaching women who have language barriers? How are governments engaging? These questions are critical in assessing community needs and information gaps. However, it is important to ask, how are we engaging women with language barriers and creating conditions for their leadership as health advocates for their own communities? How do we then turn community engagement to community empowerment? At the end of the day, knowledge is power. By giving women the tools, support, knowledge, and autonomy to assess their health status and to be in the driver's seat of their own well-being, we create a more equitable, healthy society. Empowering women enhances their capacity to engage in preventive care measures. Preventive care leads to better health outcomes, longer lives, and in turn, more empowered women. The bidirectionality and power of knowledge ownership is incredible. CLAN's approach is through an online treasure trove of informational flyers and community resources specific to the individual needs within that specific illness-focused community in varying parts of the globe. We must meet people where they're at and ensure that everyone has the tools needed to live a healthy life. So, why women? Historically, we have had decisions made for us and about our health. The United States is trying to remove the term gender from the CSW outcome document as we speak. It is time that we give women around the planet the power, knowledge, and support to go forth as partners and leaders in their own health. Women especially are intrinsically powerful community leaders. We nurture, we cultivate deep relationships, we create life. Together, we're an invincible force. We must bolster the rallying cry, nothing for us, without us, and work to change things where we are, starting with dialogue, support, and empowerment within our own communities. Thank you.
Thank you, Nadine. That was a really, I love that closing, and I totally agree with everything you said at the end there. Next we have Morgan Handwerker. Morgan Handwerker is a senior at Lehigh. She's studying political science and religion studies with minors in international relations and women, gender, and sexuality studies. She has chaired the panel at the Gender and Rural Symposium for the 62nd Commission on the Status of Women. She has been a youth rep for CWSI since fall 2018. The Center for Women's Studies and Intervention, also known as CWSI, is an NGO based in Abuja, Nigeria. CWSI envisions women empowered, liberated, and active in the creation of a better world. The Center for Women's Studies and Intervention aims to accomplish its vision through several initiatives, including education. In terms of healthcare, CWSI aims to both empower women and better the community. This is done through empowering women and assisting them in becoming leaders in the community. And we do have our NGO president for CWSI here as well.
Hi all, I would like to thank you so much for coming. As Jessica mentioned, the Center for Women's Studies and Intervention is currently working on several different initiatives throughout the Nigerian states to improve the lives and empower women. One project in which CWSI is currently focusing on is training and empowering women to become leaders in the field of healthcare. The goal is for women to take their newfound leadership skills to find solutions to stop or contain the communicable diseases that are running rampant throughout parts of Nigeria. Currently, there have been outbreaks of many communicable diseases that are tremendously impacting the population. 3 diseases that are currently outbroken in the regions in which CWSI does its work are Lassa fever, meningitis, and cholera. Lassa fever is a hemorrhagic fever similar to Ebola. One common way in which this disease spreads is through excrement. Meningitis is a bacterial disease that spreads like typical bacteria through bodily fluids. Meningitis is also preventable through vaccines. Cholera is a deadly disease that is most commonly spreads when excrement particles get into drinking water or when people consume unsafe and unclean drinking water. Essentially, when waste disposal systems are inefficient and kept separate, they can contaminate the water system. The prevention of cholera is dependent on access to safe water, adequate sanitation, and basic hygienic needs. These diseases have been spreading so aggressively and have been able to thrive due to issues with basic hygiene in an unclean environment. As you can see, the common theme within the spread of these diseases is the necessity for clean drinking water and better sanitation systems. However, accomplishing these is no easy feat. We need leaders within the community to find solutions to achieve these goals, which include further widespread access to clean drinking water and better sanitation systems. CWSI has been working hard to gain immediate relief. They have been in contact with people from the disease control unit to try and get basic resources needed to combat. While immediate relief is necessary, it is not sustainable, which can cause the problem to relapse. The ultimate goal is to implement and maintain a long-term solution. One longer-term solution, besides education, that CWSI has been working on is sinking boreholes. As of date, CWSI has helped to sink 2 boreholes in the Biminishi village, which is in the Kuje Area Council of the Federal Capital Territory of Nigeria. The boreholes have provided clean, accessible drinking water. This has been a very successful venture. It's been incredibly helpful in the aim to provide clean drinking water and thereby reducing the spread of disease. However, there's only 2 boreholes. Leaders are needed to find wider spread solutions. The boreholes also ease the hardship associated with access to potable water in the community. This burden of accessing the potable water had previously rested upon the shoulders of women in the community. The boreholes free up these women, which previously would have spent their time accessing the community and now are able to spend time focusing on their education and leadership skills. Therefore, these boreholes serve a dual purpose. Overall, CWSI is looking to combat these issues of disease outbreak by educating women on how to be community health leaders. This empowerment will set up these women to find long-term solutions to fight these debilitating issues. Nadine earlier so eloquently explained why including women is so vital. If CWSI is able to educate these women, then they will be able to improve the conditions and find solutions which will help contain these diseases. The goal is to get women who are on the ground to fight these issues, because who better to solve the community's issues than those who are directly impacted by it? We cannot expect women to reach their full potential as leaders without equal educational opportunities. Furthermore, empowering women on a community level helps elevate and encourage women to take on leadership roles on a wider scale. These issues, causes, and goals connect strongly to 3 of the 12 Sustainable Development Goals, or SDGs, of the United Nations. The 3 SDGs are number 4, which is education, number 5, which is gender equity, and number 6, which is clean drinking water. There is incredible potential to not only improve these communities, but simultaneously empower women. This project needs urgent attention to improve and save lives. I'd like to thank you all so much for your time and attention, and my information is on the sheet if any of you are interested in partnering with us on conquering these issues. Thank you so much.
Thank you, Morgan. Finally, we have Amy Ermeyer Kale and Sophia Mayone. Amy Aramian Kale is currently a PhD candidate in the College of Business and Economics at Lehigh University. Her fields of study are health economics, applied econometrics, labor economics, and microfinance. She is one of 3 UN youth representatives for the Center of Public Health. Sophia Mayone is an undergraduate student at Lehigh University studying biopharmaceutical engineering, and she is also one of 3 UN youth representatives for the Center of Public Health. The Center for Public Health is an NGO that operates in rural Nigeria and aims to be a center for health excellence and assisting vulnerable people by providing them access to quality health care. Under the leadership of the head of CPH, Dr. Okorochukwu, CPH serves as an advocacy and support network for communities living without ample access to public health and medical services. It also encourages rural communities to use CPH as a resource so that they can live healthier lives with medical recourse for when illness occurs.
Thank you, Jessica. So today, Amy and I want to describe several practices that CPH has implemented which have directly increased the number of women who use CPH's services, CPH being Center for Public Health. So Center for Public Health has been successful in increasing the number of women that use their services because their approaches are both simple and realistic. I want to start out by talking about CPH's flyer distribution system. So aside from handing out flyers, CPH uses radio programming and TV programming. They do some door-to-door programs. They have tables in churches and malls. They do a little bit of SMS text messaging and social media. However, 40% of the people who use CPH's services have access to internet. The other 60% don't. So if Center for Public Health were to only advertise what services they have and also only to post educational materials on internet sources, so through social media, they'd be limiting the number of people that they reach. That's why Center for Public Health has started this flyer distribution system where one woman comes to the clinic and receives services, and then she's given 5 flyers when she leaves. With those flyers, she's given a little financial incentive, about $1.50 USD, and she's asked to distribute those 5 flyers to 5 other women. So recently, Center for Public Health has been doing a big push for cervical cancer screening, and so one woman would come in, receive a screening, and then get 5 pamphlets for those screenings to distribute. And in doing that, Center for Public Health is directly empowering these women to not only help other women become aware of resources that are available to help them with their own health, to help them be more health aware, but just empowering them to be the ones that can distribute that information. Which, with each of these practices that I described today, I'm going to talk about a transferable application that can be taken from this example with CPH back to your organizations or communities. So really the transferable application with CPH's flyer distribution system is finding some way to distribute information that is appropriate for the environment or setting in which you're operating. So with CPH here, we're not just relying on the internet. We're using hard copies of flyers and asking people to use word of mouth and to take advantage of their social circles to get information out there. The second specific example or specific action that I want to talk a little bit about is CPH's community-based insurance, health insurance program. So Center for Public Health has a program where individuals can pay $1 a month to receive medical insurance. And CPH sets up several clinics throughout the 5 states in Nigeria in which they operate. And basically, this insurance program initially no one was really buying into it. And a lot of that was because of a distrust of the people who were intended to receive the insurance. People didn't want to pay $1 a month because they didn't trust where that money was going. And so early on in the process, when CPH started to implement this problem was recognized. And what CPH decided to do was to decide to have one clerk from each community in which this insurance was the insurance program was happening who would help with the bookkeeping and who would be doing the money collecting. This clerk was a member of the community, so either a church leader or someone who is visible and also known by members in the community, someone who could be trusted. After CPH had started doing this and chose a clerk in each of the communities, people started buying into the insurance program. And at this point now, the insurance program is in 8 different communities with 6,700 beneficiaries. So that's 6,700 people who fall under this insurance. And really, what was most successful about the implementation of this community-based insurance program and what continues to help it be successful is that it's done transparently and that the social situation around in these communities was recognized in the implementation of it. So really the transferable application with this is just being aware of, I guess, the social situation in an environment in which you're trying to implement something, and also using transparency in your practices. So now Amy's going to talk about just a couple more, starting about high school girls learning and educating other women on giving breast exams.
Thank you, Sophia. Can everyone hear me okay? Awesome. All right, so I'm going to talk about 3 things that CPH does and has done in the past to empower women to become health leaders. The first of them is the women's breast exams. So what CPH does is it goes into high schools and it teaches girls how to perform breast exams properly and why to perform them and when to perform them, with the goal of making them empowered in this knowledge of how to perform breast examinations. And then they go out into their homes and teach their mothers, grandmothers, aunties, and make them also empowered in the ability to perform proper breast exams. A transferable application of this would be to find an access point to educate a certain part of the population who has the ability to go out and educate more individuals as well. So that's the first. The second is radio broadcasting. So CPH, the Center for Public Health, has, before I go on, I should mention that most of the staff at CPH is female, and additionally, 90% of the volunteers are female as well. So that's also empowering women, knowledge-wise. Okay, radio broadcasting. So CPH has a channel that's dedicated to health-related information that broadcasts information to over 6 million people on health, right, and on healthcare. In addition to this channel just broadcasting information, there is a call-in session where people can call into the radio channel with questions related to health and access to health care. And during these calls, their questions are answered directly and immediately. For instance, during the call-in sessions, we have up to 30 callers per session with their questions being answered, educating them as well as the listeners on whatever issues are being discussed. The transferable application of this is to make information easily accessible to the most amount of people, right? So like Sophia mentioned earlier, having access to internet is not something that's 100%, right, in the areas where CPH works. However, radio is something that's very available. And so using this method of promoting information is one way of empowering as many people as possible, especially young women. The last of this is the setting up of tables at the mall. So what CPH does is it takes a car full of their staff to local malls to set up a table with flyers, pamphlets, and information, both on the services that CPH offers and also on just general public health information, educational material, right, such as information on non-communicable diseases and HPV. One of the reasons this is good is that it takes advantage of a highly visible public space to target the most people, right? So the staff who are going out to these malls are also not passive, right? They don't sit and hope that people walk up to them. They interact with the mall goers, not in an invasive way, obviously, because then it's rude, but just in an opening and welcoming manner. They also wear bright colored T-shirts, CPH T-shirts, which helps them be distinguished from the crowd. It's also important to note that the staff can answer questions that are asked of them, right, in these sessions at the mall. Transferable application would be to stand out in public, highly visible spaces, and highly visible spaces to get information out to the most people possible. To summarize, the CPH has found success by using simple practices that are appropriate for the environments in which they operate. Right? They use skills to empower young women to become health leaders in their own communities. So now Sophia is going to talk about flyers that you found on your chairs and give you some information about that. Thank you.
Thank you, Amy. So all of you should have found flyers on your chairs when you came in. There might be some extras on chairs that don't have anyone in them. On these are our contact information. There is a general email, Lehigh CSW, that is a point of contact for all of us, a little summary of what we talked about. And at the bottom there is a QR code. Those can be scanned on an iPhone. If you just open your camera app, it will pop up. On an Android, you have to hold the home button, swipe up to the Google equivalent of Siri, and open the camera through there, and your QR code link will pop up in that way. If you're having any trouble accessing the QR code, you can email the Lehigh CSW email requesting the link, and I will just send it to you, or one of us will. In that QR code is basically what we're calling a toolkit. And this toolkit contains information on 5 common women's health concerns. And what you can do, or what you'll see when you open up this toolkit, is a little bit of information on them, but the really important part is links to further resources. These resources include a 4-minute video on how to give yourself a breast exam, or a list of common signs to look for that may indicate women's heart disease, these sort of links. And so we're hoping that this QR code and this toolkit can be used in your communities and your organizations as an educational tool. Because as Nadine and as we kind of touched on earlier, education leads to power. And if we're looking to empower young women to be community health leaders, they need to be educated. And even this simple little infographic that will pop up when you scan this QR code, that's knowledge that we all will be gaining. So let this serve as a little bit of a challenge for you guys to distribute this information. Scan the QR code, get the infographic up, and send it to 5 people. Send it to 3 people. Ask them to send it along. There are, 30 or maybe 40 flyers in this room. Let's see how many we can get and how far we can get them to go. See if we can get them to go out of New York City, to leave here somewhere. Because really, if we can recognize that empowering women is done by educating them, then that's going to help us go really far in terms of finding a healthier future.
Thank you, Sophia, and thank you, Amy. At this time, I would like to open the floor to a dialogue, a Q&A session. So if you would have a question, I would ask that you raise your hand first, and then we can kind of go from there. Or comments. Go ahead.
Okay. First of all, I want to say thank you for putting together this session. I'm quite delighted that everybody here is so young. I'm sure everybody's under 25. That's thumbs up. So you're higher than me? Yeah. Okay. Anyone should announce. Yeah. It's all right. Sorry. I know it's a panel put together by young people. I've attended several panels, and most of the panels will see they are all 40 and 45. So I think it deserves a round of applause. Thank you for putting this together. My name is Dr. Njebe Elemiani. I'm a consultant radiologist. This is my 13th year of practice, and I practice in Nigeria, Africa. I'm head of Center for Public Health. I know you're doing a lot, especially right now. I know you're looking for funds for Cevarex or Gardasil, if I'm not mistaken. Yes, for cervical cancer. But I wanted to find out, are you, because because right now we're talking about all inclusiveness. I didn't hear you mention anything about disabled persons. Do you have that as part of your work plan? Because we cannot afford to leave them out. Even when you take a look at broad data, we have few data running across continents talking about the number of disabled persons that have been able to access healthcare. I think we should also talk about it because healthcare for disabled persons is a complex thing. You need to be able to pay attention to it, to be able to extract information, and that will be another source of aid if you're looking for aid to run your project. Overall, I must commend your initiative, and I see that you've gone digital also and going to the grassroots. I know if you teach a child something, you teach the community because the whole house gets to know about it. So that's thumbs up for me. Thank you.
It's a very great question about disabled people. There's mentally disabled, physically disabled. I can say that there isn't any specific work being done to address that population. However, it's not being turned away. Like, we won't turn away people who are physically disabled because they are. However, it is a good point to specifically, address and access them.
Especially in regard to your comment about disabled persons, CLAN specifically, the NGO I've been working with for a while, CLAN, it's short for Caring and Living as Neighbors. It's an Australia-based NGO, but we do specifically work a lot with patients who have disabilities as a result of their chronic illness. So people with Duchenne's muscular syndrome, people with congenital adrenal hyperplasia, osteogenesis imperfecta, the list goes on and on. People in Pakistan specifically, we work with people living with the effects of polio. So really kind of champion disabilities, championing rights, and making sure that people know what their rights are, that they're entitled to essential medicines, that they're entitled to care, and really allowing them to come together as a community. Because when you build communities specifically focused around a specific disease or a specific health outcome, you really create a space where people can have conversations. They can go outside of a clinical setting and really talk to one another about, hey, what works for you? How have you been coping with your illness? What strategies should I employ? And so we found in our work that the most empowering thing we've been able to do for communities is to give them the capacity to advocate for themselves and kind of help them along the way if they ask for it.
Next question. Keon Campbell of New Zealand, and I think the grassroots information sounds amazing. And I was wondering if Amy and Sophie would have any figures confirming a bigger uptake, say, at their clinics after the likes of the radio Q&As, or say going to the malls.
So it's a little tricky to keep track of the exact figures. So I wish I could give you a concrete number, but I don't know one off the top of my head. I do know that there is a significant increase. Again, I wish I could give you a percentage or an exact number. I don't have one, but I know that it's a lot. And I know that, again, Amy cited this figure, but there have been a couple of the radio broadcasts, and when the lines open up for phone calls, have received up to 30 calls. And a CPH does see a lot of people coming into their clinics that say, I heard about you on the radio, or I heard this on the radio. So, yeah, it is, yeah. Thank you.
Can I contribute something? In the month of October, we kind of hashed up the free breast cancer screening back home in Cross River State. There's a way to keep tabs. You have to be able to evaluate if this particular method is working for you. So when you go on social media, you could give them like a hashtag or a code. You can say PAP001, that's for the Gulfing Capital Foundation 001. So when they come to clinic, they read out to you the code. You have a register. So you say, for this month, we had certain referrals to this social peripheral clinics around the region. So at the end of the month, you collect together. You can actually do an M&E and see if that method is working for you or not and see how to re-strategize. That's my own thing.
Very nice. Thank you.
Thank you. Thank you. Thank you.
Do you need the microphone?
No, I have a strong, loud voices. Good afternoon, everyone, and thank you very much for this session of young people. And my name is Kemi. I'm Nigerian, but I live in Uganda, and I do work for an organization called the AIDS Healthcare Foundation. And what we do a lot of work with young women and girls, in addition to the general population when it comes to HIV. Because I'm hearing a lot about Nigeria, and I'm wondering. You seem to focus a lot more on non-communicable diseases and all. Is there anything with respect to HIV, what the Center for Public Health does? Because the reality of it is that you can't address non-communicable diseases in as much as, like, you can't generally address health without talking about HIV, and that's because when we look at the prevalence or the incidence rate, we discover that, for example, for young people, young women and girls have like highest numbers of new infections, and they're all interconnected in a way, especially if you're working in rural communities where there's lack of access to water, there's poverty and all of that, and of course you have high rates of transactional sex, just to make ends meet. So I want to know, is there anything in your programs or projects that actually focuses on HIV and AIDS, especially for young women and girls?
Thank you for asking, Kemi. That's a very great question. CPH definitely has a foundation of spreading information on HIV and AIDS, prevention, care. The center also provides health care to people with HIV, right? Screening and also the medications for it, checking viral load. That's something that is the background for CPH. Right. Very recently, we've taken on cervical cancer and the screening for cervical cancer, with the goal of, or the reason for this is that there wasn't a lot of information about it, right? And it's something that attacks women primarily. So that's the newest goal or branch of work being done by CPH. But you make a very great point, though.
There's also a correlation between cervical cancer
exactly,
and
HPV. And exactly.
Every 5 women, 1.
Yeah.
That's the main.
Thank you.
Do we have any other?
Yeah, I just want to add to what the question she's asked. What has happened is that over the period, there was a lot of work done around HIV and AIDS in Nigeria, and the prevalence has reduced a lot. It has. And because most of the hospitals now have centers, the heart-to-heart centers where you can go, you refer this because of stigma, and we don't kind of stress so much because people know where to go to now, and we keep reminding people, but that's really like not the very urgent thing now because of the awareness that has already been created.
I beg to disagree with that because I work in the field of HIV. The general feeling is that there is such a high awareness, but it's one thing to have awareness, it's another thing to have knowledge. And we see a gap. Even just recently, Nigeria released its survey on the very first high impact survey we're doing as a country that was largely funded by the US government. Yes, the prevalence is down, but we still see a lot of gaps, especially for women. We see gaps.
Cases.
Yes, we see a lot of new infections. We're seeing gaps even in access to viral load. There's still people who don't have access to treatment. Stigma is still very high. So the scenario is that HIV is still a crisis. It's still a big problem. And for a country like Nigeria that has such huge population, you want to keep an eye on the disease because you blink for a moment, you could have it just skyrocket. So.
Thank you. I'm sorry I missed your name, Sister
Ambrose.
Thank you.
Are there any other comments or questions at this time?
I'm Dr. Holly Shaw. I'm a director on the NGO DPI Executive Committee with my colleague Nadine, and I'm the representative for the International Council of Nurses and the Nightingale Initiative for Global Health. So I'm really, really interested. And thank you so much, not just for the presentation, but because of your presentation, I'm going to sleep a little better tonight. You've managed, on one page to give us so much information. I've been tracking down people having to go on LinkedIn because they've run out of cards and we don't have their contact information, and I'm just amazed how much information you convey to us and how much information we're taking home with us that we can then use and pass on. And I'm just so relieved that you guys are in charge and doing so well, and grateful on behalf of all of our patients and all of humanity. You've done a great job, and I know you'll continue. Thank you.
Thank you. That is very kind of you. If there are no questions at this time, I actually do have a question. So a lot of you on this panel talked about different ways, different steps that we can take to make women and girls more empowered and become leaders in their community, health leaders in their community. But is there one step that all of you maybe would be able to agree on as being, you know, a beneficial first step that you can take across all of your NGOs, across all of the work that you do?
I mean, personally, I just think after listening to everybody talk and after all the work and all the comments that have been made, I really feel like education is the first step to tackling these issues, because without education, you have nowhere to go. And like Nadine so eloquently did say, knowledge is power and support, and it truly is one of the foundations for almost everything. So I think we can all sort of agree that education is the foundation for healthcare.
Yeah, I think that's perfect. I mean, I think education and also bridging the gaps where they exist in education. And as our colleague so brilliantly said, there's a substantial gap between awareness and knowledge. And I think it is really critical to ensure that we identify the communities kind of who have these gaps, who are experiencing these gaps, and their health outcomes are more negative than their colleagues perhaps. And I think it's really critical to ensure that there is equity in education, that we're making sure that women across the board, across county lines, across party lines, across everything, are accessing health information that they need, whether or not it's something that they think they need to hear. I think it's really imperative that we at least make that information as accessible as humanly possible.
I totally agree. Education was the first thing that popped into my head. I just wanted to add that I think education is so important because it gets everyone on the same page. And so if we're going to take a community of young women and we want to say we want to empower all of you to become community health leaders, everyone needs to have the same understanding of these non-communicable diseases, or what's available to help people who have these non-communicable diseases. So I think in the realm of education, it's just really important to get everyone on the same page in that first step as well. Thank you.
I'll just add a quick comment there that it's important to keep it simple, right? So it is true that education is power, knowledge is power, but keep it simple, keep the message simple, something that they can really make part of who they are, I guess. Get straight to the message, keep it simple and accessible as well.
No, so going off of everybody's saying education, I think at some point over this room, there's been at least 30 people who have been here at one point and who have seen this infographic. So if each person in this room spreads that to one person they know, that's 60 people who have seen this infographic. And if that person just spreads it to one more person, that's 90 people that we've already reached. And so please, please, please spread the knowledge and the information.
The physical flyer itself, once you've scanned it, once you've taken a picture of our contact info, pass it on to a woman that you see at CSW who you think could benefit.
I think as an educator, and I'm a college professor, education isn't the answer or enough. What you've done is more than that, because I always used to say that teaching kids on a Tuesday morning about HIV or something is not necessarily helpful on a Saturday night when they've had 6 beers. What your generation can do better than we can is not just provide education, but you've each mentioned being able to use that knowledge. And that's the key that sometimes we miss. So you've been able to combine the education with a skill or a tool that makes it usable and effective. And to me, that's the real difference than just having abstract information that you really don't know what to do with. And I think that's a mistake we often make that you're not doing.
Thank you.
Oh. You want the microphone?
You do really serious and necessary work. I wish you good luck. Thank you.
Thank you.
So much.
I do want to go back to that, kind of that issue of awareness versus knowledge. So we're sitting here today saying how important it is to bridge that gap between awareness and knowledge. But what do your organizations do that truly bridges that gap between awareness and knowledge? What is something that we're doing that all of you are doing that really is providing knowledge to people rather than just, okay, I'm aware, I know about it?
I think for me, it's the radio station where you can call in with your specific questions and they are answered right there, where it's, not only do they know that they can go there, which is access, but then they have specific questions that are answered that makes the knowledge now more practical and applicable to them where they are. And it also helps whoever is listening if they have those questions as well.
CLAN specifically, my NGO, we do a lot of work with local communities. So as I was explaining earlier, we build communities surrounding certain diseases so that these communities are able to come together, not only disseminate medical knowledge that they've kind of accrued as a unit, but are able to just disseminate things that you maybe wouldn't think of if you're the practitioner sitting in a room, things that a mother would encounter when she's taking care of her sick child who has diabetes. So it's, I think, being able to give communities that next step of not only just the health education, the health knowledge, but also giving them a space in which they can communicate, in which they can kind of share stories, they can laugh, cry, and I think that ultimately is one of the most valuable things, and specifically one of my favorite parts of the organization I get to work with. Because these communities, we build flyers for certain diseases, and we have all this information on basically a rights-based approach to care. So we'll translate it into every language within that country, even smaller dialects. We work with a team of people. We'll work with national health institutes to make sure that the knowledge is unpretentious and is presented in a way where people really can identify with it and take it home and actually use that knowledge.
Do you need a microphone?
Maybe not. You talked about non-communicable diseases, and I think you mentioned 5. What were the 5, please?
Wait, did you say communicable or non-communicable?
Non-communicable diseases.
Non-communicable diseases. It's specifically our organization. We work with diabetes, congenital adrenal hyperplasia, osteogenesis imperfecta, Duchenne's muscular syndrome, rheumatic heart disease. We cover most NCDs, and if a community comes forth with a condition that they would like to add to our list, we always are willing to embrace that with open arms and get people on board.
Okay. I say for CWSI, because it's not every information that I expect Morgan to present at her presentation. At CWSI, we have, in addition to education, we have radio program, just as she has said. We have radio program that the women themselves carry out very often to disseminate information, to reach out to those who need to. And we have women groups. We form women groups, coalitions, and all that, where we bring them together, give them the information, and a woman from a household of 5, she goes back, 5 people are already informed. And then the women, without looking at it in a very, derogatory manner, but women are very means of disseminating information in the community. So when they come together, you give them the information, the likelihood of that information going around the community is very high. We also engage in town hall meetings a lot. Because when you have town hall meetings, you bring all and sundry together, you pass the information, and you educate them, it goes further to the grassroots. Yeah.
Can I just ask a follow-up question on the town hall?
Yeah.
What is usually discussed during the town hall meeting?
The town hall meeting, when we come together, we kind of allow the people within the community to come up, roll out the issues. They are the ones to tease out the issues as it affects them, and everybody, will start discussing it. And at the end of the day, they also will prefer, they will be able to arrive at a solution in the course of discussing. Because when somebody brings up an issue and probably he or she didn't analyze it very well or didn't look at it from the perspective of others, but hearing from others, they will now begin to, reason together, and at the end of the day, they will be able to arrive at a solution. Ours is to animate and make sure we remain within focus.
Thank you. Going off of that, something, it's okay. I was going to say earlier is that something I'm really proud to work with WSI about is how you guys are able to go in and give the knowledge, but also train and empower women to take the knowledge and build it off sort of how we're doing with these flyers. So it's not like, okay, we come in and we say XYZ, we teach you XYZ, but XYZ, and here's how you apply it into the real world. So it's not just here, go to the radio station. It's here, and this is how you can take it and what you can say to spread the message. So I think that's something that CWSI does really, really, really well.
Absolutely.
Bridging the gap between education and knowledge and awareness.
Yes.
And that reminds me of one other thing too. Is a lot of times when NGOs or other organizations that are doing such great work in communities, they often leave. Some of them have to kind of pack up and leave, or they're unable to continue with their operations. How do they do capacity building so that the community is able to carry out the same tasks by themselves, knowing how to do these things? What are ways in which your NGOs are providing capacity building for health initiatives for young women and girls to become those health leaders?
So I think one thing would be the support system that comes along with it. So at CWSI, it's women working together. So if I have something that I'm not 100% sure about, for example, I can go to Nadine, and hopefully Nadine can fill in the gaps, or if she can't fill in the gaps, maybe Amy can fill in the gaps for me. So it's sort of a support system where it's not one person doing all the work, but it's everybody working together to make everybody else and the whole community as a whole better. And I can comment specific to CLAN's work. We do a lot of capacity building with our communities by ensuring that if we were to exit that community tomorrow, would they be able to sustainably continue the work that we have been doing? And if the answer is not yes, then it should be within the week. And so we try to organize our own campaigns, our own initiatives in a way where it's not us going into a place and dropping a program. It's us working with the local community, working with the National Institutes of Health, working alongside local practitioners and specialists and professors, and engaging them and saying, okay, we will help give you the tools to establish this initiative in your own communities. And additionally, with microfinancing, we're able to provide some microfinance loans so that families don't go into debt. Say they have crazy expensive treatments for their child. It's really easy for someone to default and kind of bankrupt themselves just paying for things like insulin in some countries. And so it's really critical to give people that support system, but also ensure that it is sustainable, that when the NGO does ultimately exit its work from that place, that the community can continue on with the work and with the materials that have kind of been left behind, and really champion it as their own. Because as we like to always say, it's not our programs in a place, it's the community's programs. So.
I would like to offer, I guess, two examples. The first one I would say is integrating the community members themselves. With CPH in the insurance, we have members of the community who are the ones that are doing the bookkeeping. We've integrated community leaders into our programs, so it's not just us putting these programs into the communities, but it's the communities ultimately helping to run them themselves. So that's the first one. And then the second one I would say is keeping the education simple. And Amy said this earlier, but making sure that the information is accessible. And I guess if we're talking about, like Nadine said, if CPH packed up their bags and left, would anyone remember the educational material that we've left? So making sure that the education that we're doing on non-communicable diseases or on services that people should reach out, that those are simple enough that people feel like they can really take ownership of the material.
And that does remind me also of something you said before, Sophia, that it's really important that the community trusts the organization, because you said before that they weren't buying into the insurance program because they didn't know, well, where's my dollar going to end up? And I think it is really important, that civil society, becomes a part of the community. These organizations are becoming a part of the community, and that they are transparent. So I definitely do agree with that. Do we have anything else? Any other questions? Okay. But something else that I thought was really interesting too is we have all kind of been talking about this idea of contextualizing global problems. So health issues are a global issue. It's a global problem that we all face, and it's important to realize that we can't just take solutions from one country or even one local community and just drop them somewhere else. And a lot of the panelists here today have actually, kind of mentioned that. I was wondering kind of how the context of each of your NGOs, historical context, the people involved, just locally where they are, how has it had an effect on the types of solutions that they put forward? Do you think that there would be different solutions if your organization was in a different place?
I think it's absolutely contextual. I mean, I think solutions are driven by the conditions at hand. So if you have a country in which insulin is subsidized and people can access it, that's not really going to be at the forefront of your concern within those communities. If you have one where it's 50% of someone's monthly salary, it's going to be a way different approach to type 1 diabetes than you would have elsewhere. So I think it's also really imperative to liaise with community leaders, to liaise with community public health practitioners, and really, really dig down and figure out, okay, so what's really behind the scenes of health issues in this specific place, and how can we kind of enable the progress going forward and somehow change policies or change healthcare. What can we do to ameliorate this situation? So I think it's really everything has to be contextualized, because I don't think you're going to have two people having the same approach to the same NCD. So I think it's really important to also account for social determinants of health. Not everyone's going to respond to the same disease in the same way. You look at birth and death rates in the United States, infant mortality rates for people of color versus white women. It's people of the same education level, the same socioeconomic status. It's drastically different. So you really need to contextualize everything. I mean, it depends on what social conditions a person grew up in. It depends on what their environmental exposures are. So I think it's really imperative to dig down and get all the info.
I will just add that idea of being able to fit into the environment that you're serving is something that I think CPH has done rather well with not just the radio broadcast, even the insurance program, having it being run by community heads. They make up the board for each group of insurance carriers or participants, having the money being transparent, making sure people understand who is using it, who used it this month, right? Who paid this month, who didn't pay this month. Just having that information being readily available was necessary for the environment in which it was being implemented. So I think it's a great example of that approach.
And I think, oh, we do? Okay, go ahead.
Do you get invited into these communities to do the work that you want to do? And if so, who invites you? And who do you
Yes.
liaise with?
The people invite, at least for CWSI, they are invited into the communities, and they're invited in by the members of the communities.
Likewise with CLAN, we are invited into the communities by local practitioners who kind of get wind of our work, and also if there is an emergent health crisis or an area in which there's just a really prevalent NCD, we will reach out and just say, like, our services are available. This is the work we do. We don't impose in any way. That's something that my NGO president specifically feels very, very passionately about, that it's the communities approaching us with the request to liaise together and improve conditions for everyone in their local area living with NCDs. It's very holistically driven by the local communities, and I think that's something that we're all very proud of. So.
And how long do you think it takes you to become effective?
That I am not
Can you
sure.
repeat the question? It's hard to hear.
How long does it take for your organization to become effective?
Can we,
Yeah, please.
yeah,
We have an NGO
can
president.
we respond?
Oh, go ahead.
Yes. When once the community invites you, there is always an issue or a situation they want you to address. So they are inviting you already, and you accepting to go into that community is already an effective means of solving or addressing the issue. And because they invite, we go in there with goodwill and our skills, what we have to address the issue. You notice that we have maximum cooperation from the community because they trust and believe in us, which makes it easy. Before even you finish the first phase of that work, you are already effective because you already gain their support. You have the community buy-in that will enable that work to drive in that community. So it doesn't really take time as long as the people, are willing. Yeah, right.
I want to see on the insurance program initiative. When it first started, there was a lot of resistance, so there wasn't any invitation. However, when it became successful in some communities, then CPH was invited to start that sort of idea as well in other communities. So I guess based on the success of the community-based insurance program in certain communities that they had taken the initiative to start it in, then they got invited. Pardon?
And the word got around.
Exactly,
Yes.
and the word got around. Exactly. Absolutely. Thank you.
I was also thinking about, and this, kind of has to do with the local community and making sure that, we're involving them, but especially in the work that CLAN does. There's the issue of balancing indigenous tradition with Western medicine, I think. How does CLAN present medical information to the local community in a culturally sensitive way?
So our president is she works in the Indigenous health sector of Australia. So she is just incredible in working with and communicating with that community. And specifically, we have a bunch of Indigenous people from around the world actually on our team. We started a movement called Indigenous NCDs, and it's led by a handful of Indigenous youth and practitioners working in New Zealand, working in Australia, working in Canada, the US, you name it. And so we pride ourselves on having something that is Indigenous led so that we're able to really effectively communicate information tailored to a specific culture's traditions and their own practices. So making sure that things are translated into languages that will convey information best, ensuring that things are respective of traditions, that you're not using terminology that has a history of oppression behind it, and also acknowledging the land that you're operating on. That's a huge component of working with Indigenous communities. And I think it's really imperative to just reach out and to ask questions and to not shy away from asking, okay, so how can I present this in a way that's most culturally sensitive, that's most coherent, and where knowledge can be most easily transferred. I don't think there's any shame in asking those sort of hard questions and really digging for those answers, and that's what we seek to do. So.
Have any of the other NGOs, encountered a similar problem?
I don't know exactly how they got around it, but I do know Dr. Seafine mentioning that, bringing up the issue of cervical cancer and talking about why it's important to screen, and people saying to him, like, how dare you, God forbid, like, why are you trying to bring up cancer with my name? Like, what are you saying to me? I mean, these are typical responses he says he's gotten. Just, I don't know, getting past the idea of, I'm not trying to say you have cancer because I mentioned it in the same sentence as your name, but let's check and make sure that you are clear. I guess, does anyone have any suggestions of how to take it one step further from, I'm not trying to put this on you, I'm just saying it's something we should consider and check, as women.
It's an issue. It's an issue for women generally, and we do a scan to see whether you have it or don't have it. And if it's very early, you can do something with it.
I think another way you can also break through that is if you also engage the community women leaders. They're usually the most, I'll say, exposed and advanced in the communities, and they could be leaders of the market, they could be leaders of farming, they could be anything. But every community you go, you have grassroots women leaders who have also had opportunities to attend a lot of these conferences by virtue of their positions. And what you do with them is you bring them first into a dialogue and you let them know why you want. Now I'm speaking, for example, in the African setting, because virtually every community has community leaders and gatekeepers that are listened to. And that also includes even the community head or chief, as it were. In some places they have a community king. Now those are the gatekeepers, and they're the ones that if they tell their communities to go, they will go. So it's usually very important to get them to buy in to whether it's cervical cancer screening, whether it's HIV, whether it's gender empowerment, whatever it is you want to do. Once you get their buy-in, more than half of your work is done, because they are going to now be the ones who help you convince their constituencies or their followers or their communities why it is important for them. And I say that because we've also seen that when we do our work in communities. We try first to get the community leaders, the community chiefs, women leaders, youth leaders, bring them to a table to explain to them why this is important. We're not saying you're going to have cancer, but you never know. So once you get their buy-in, they do the legwork that you don't have to do. You just need the services. Thank you.
And that being said, we would love to hear from you. What are some interventions that you've all, in your experience working with various organizations, what have you found effective in connecting with young women and empowering young women to become community health leaders? What are some experiences you've had or some suggestions you may want to convey to the room to carry forth into all of our individual work and organizations?
I would say one of the key things that we have seen very effective for us with young women and girls mentorship. Another thing we're working on is building young advocates. We're trying to build young advocates, and what we do is we give them an agency to actually champion their own demands. So we create a forum for them to also, whether it's interact with parliamentarians. So like when we say nothing for us without us, it's the same thing even with young people. And I think it's stronger even with young people. So part of what we do in my organization is we are empowering them in terms of information. And we're also bringing them to the table. For example, if we are having discussions with parliamentarians or policymakers, as it were, we ensure that they are represented in those platforms. Because when we do that, we realize that we give them the confidence to know that I can actually negotiate, with these people who, before now, they're like our parents' figures where we can't really tell them what we want. But in this space of development and of health, we can actually make demands of what we want. So we do a lot of investment in terms of mentoring. We identify young people who have the potentials to be very articulate, very vocal, and very strong in terms of engaging with the older population. And we take them through what they need to do. So they go through policies. These are the gaps in the policies. Another thing that we have done is we've learned to simplify policies in a way that is easily understandable for young people. So sometimes we could get a policy on stigma and discrimination, for example, and we simplify it in a way that is done into like a comic-like book, because that's what young people understand. And then they read it, they get the gist of it, so it becomes easier for them to have a conversation on that policy. So when you talk about language and materials, it's also, that's a good way as well for us, but it's also simplifying policies in a way that young people can understand what you're saying. Because some of these policies, as a lawyer, I will tell you, for the layman, it's like bogus. Like, I don't understand what you're saying. But when we're dealing with young people, we simplify the policies for them so that they can engage. But we also make sure they have a representation at the table. We do not take any decision about young people without hearing from them if it is okay or not. And I think sometimes that's where we miss it with young people. We sit in boardrooms and make all these big decisions. We don't ask them, what do you think? Does this work for you?
Thank you.
Thank you.
And if I may add to what she has said, in CWSI, we try to build a cluster of young people around, build an institution of young people in communities, and which we always anchor on human rights. Because when we build them, we try to, build human rights knowledge in them, so that whatever they will be doing in the community, they will be guided by the principles of human rights. Because sometimes the young people, they are impulsive in their thinking and in their behavior at times. So when we build them around that knowledge of human rights, it guides their actions. And when we do that, we kind of institutionalize them in communities. And we now, from them, we can reach out more to other groups in the community, either the traditional leaders, either the women groups, and others, because they are in that community. They understand the dynamics of that community. They are like our eyes in that community, leading us to say, we need to pay attention to this. This is an area of importance. And when they lead us in the community like that, we are able to reach to the real problems of the community, and solutions now reside on them. They are like continuing what we have started, because they are there. We build them, we build their skills in some of these areas, and at the point that we are withdrawing from that community, there is already an institution established in that community that continues driving that cause.
Thank you so much.
If there are no other comments or questions at this time, I would like to conclude this panel. Thank you everyone for coming. Thank you so much. I want to thank the panelists as well. And we look forward to speaking with you and dialoguing with you, at the end of this.
That's beautiful. Yes, congrats.